There is a war unfolding inside of American healthcare, and most people on the outside of the hospital walls have no idea it's even happening. It's not a war with bullets. It's a war with ratios. It's a war with exhaustion, a war with silence. Across the country, states like Wisconsin are once again debating laws that would mandate minimum nurse-to-patient ratios and ban mandatory overtime. On paper, that sounds like common sense, but in reality, it has ignited one of the most explosive battles in modern healthcare leadership. Because behind every staffing law is a brutal truth the system has avoided for decades. Hospitals say rigid staffing ratios will close units. Executives warn costs will rise, and administrators argue the workforce simply does not exist to meet those numbers. But frontline clinicians know something else. They know the current system is already operating in crisis mode. Nurses managing 6, 7, 8 patients. ICUs are stretched beyond safe limits. Clinicians staying hours after their shifts because there is no one left to take the handoff. And then we ask the most dangerous question in medicine: how much risk is acceptable? Because that is what staffing really is. It's risk. Every additional patient increases the probability of error. Missed medications, delayed interventions, subtle changes in a patient's condition that go unnoticed until it's too late. This is not theory. Research has literally shown that safer nurse-to-patient ratios reduce mortality. It decreases complications and it improves outcomes. But here's the uncomfortable truth that makes this conversation volatile. Hospitals are not only healthcare systems, they are economic systems. And labor is one of the largest costs in healthcare. That means staffing decisions are not purely clinical decisions. They are financial ones. This is the collision point where patient safety meets hospital economics, where clinicians feel abandoned, and where leadership faces impossible math. Because if ratios become law tomorrow, many hospitals truly would struggle to even meet them. Not because patients' needs disappeared, but because the workforce pipeline has already been stretched to the breaking point. Burnout, early retirements, nurses leaving the profession entirely. So the real question is not simply, should staffing ratios exist? The real question is far more strategic. How do we rebuild a workforce large enough, supported enough, and protected enough to make safe staffing possible? Because legislation alone will not fix a workforce collapse. And ignoring staffing safety will only accelerate it. This debate is not about nurses versus administrators. It is about whether the healthcare system is willing to confront the structural reality it created. Education pipelines are shrinking. Clinical workloads are increasing. And the demand for care is exploding as the population ages. You cannot run a modern healthcare system on exhaustion and hope. Safe staffing is not a political slogan. It is a systems engineering problem, a workforce sustainability problem, and ultimately a patient survival problem. So the real question and the real challenge now is not choosing sides. The challenge is building a healthcare system where safety, sustainability, and economic survival can exist all at the same time. Because if we fail to solve that equation, the staffing crisis will not stay to debate. It will become the defining collapse of the healthcare workforce itself. And when that happens, there is no law, no executive order, and no healthcare policy that will be able to save the system. The time to confront is now, not when the workforce is already gone.